A very good evening and a warm welcome to everyone who's here this evening to join us on this wonderful webinar. A very, very warm welcome. And I'd like to say that Empower T1D and Tie-Up have collaborated together with the idea that we will be sharing education and awareness in the field of type 1 diabetes. So who exactly is Empower and what do we do? So we are a group of highly motivated clinicians, diabetes educators, support group type 1 community leads, as well as advocates who have been working together in the field of type 1 diabetes. We are collaborating and working together with respect to conducting webinars, education sessions, creating more awareness in the field of type 1 diabetes, and also collaborating together for research work. So with this and a very short, intro, let me introduce all of you to Dr. Sanket. He is going to be our moderator for today. So Dr. Sanket Pense is a consulting diabetologist from Nagpur, from the state of Maharashtra, India. His core area of interest and work has been type 1 diabetes, obesity, diabetic foot, and he has been working a lot in diabetes research, education, and management with his Trust Dream. And this trust focuses on working in the underprivileged type 1 diabetes children groups in central India. With that, I hand over to Dr. Sanket Pense, and he will take forward this enlightening session for this evening. Thank you.
So thank you, Riddhi, and thank you to the Empower Group for this opportunity for me today. So without wasting much time, we are having exciting lineup of the initial talk by Dr. Inge, and then followed by a very interactive panel discussion with three very expert panelists, Miss Melissa, who is a type 1 advocate from UK, Mr. Harsh Kohli from India, who is a type 1 diabetes advocate, as well as Mr. Nitin Somsundar, who is also a passionate type 1 diabetes advocate from India. So first we'll have the talk by Dr. Inge, who is a pediatric endocrinologist, and she's also founder of Diabetotech. She is practicing in Belgium in the University of Ghent. So with this brief introduction, I would request Dr. Inge to start her lecture.
Thank you, Dr. Saket, and thank you, Riddhi, for organizing and for inviting me to this webinar. I'm very grateful for all the individuals that are organizing these things in their free time for people with type 1 diabetes, and I think it's amazing that you're doing this. So thank you for organizing. I will share my screen. I'm going to talk to you today about connected devices. And DIY pumps in type 1 diabetes care. And I want to start with some terminology first, because connected devices, with that we mean insulin pumps that are connected to glucose sensors. These are also called closed-loop systems and sometimes called hybrid closed-loop systems. And I usually use the term automated insulin delivery systems or AID systems. Some people use artificial pancreas or artificial pancreas system, but today I'm gonna call them AID systems. And then we also talk about DIY pumps. And just to be clear, these are not the pumps that you can build yourself. We are talking about the algorithms that you can build yourselves. So it's actually DIY automated insulin delivery systems or DIY closed loop systems. And I usually use the term open source AID systems just to bring the focus to the fact that they are freely available on the internet. And it's not totally DIY, it's not do it yourself, because there is a whole community there to help you. But DIY is, of course, the most known term. So that is what we're going to talk about, automated insulin delivery systems and open source AID systems. And we're talking about this because actually these systems, these connected pumps, are the standard of care for people with type 1 diabetes, because the results in the studies are so good, and they are really the best, the most effective and the safest way to deliver insulin to people with type 1 diabetes. And in India, there is one commercial system available, which is the Minimed 780G. And there are also some open source AID systems available. So these are the free apps that you can build yourself, the DIY systems. And there is a system for Android, and there are also, which is called Android APS. And there is also 3 systems for iPhones, which is called DIY Loop, iAPS, and Trio. The most used open source AID systems are Android APS and DIY. The reason why this is so important, especially in India, is because there is no reimbursement for the insulin pumps and the sensors. So people have to pay everything themselves. And this is probably the biggest barrier in starting these systems. We know that the Minimed 780G will cost 600 lakhs as a startup cost, and then 20 lakhs per month for the consumables. But an open source AID systems only cost around 130 lakhs, with the consumables 10 to 11 lakhs per month. So this really makes this standard of care technology more accessible to more people with type 1 diabetes. And that's why it's so important for us as physicians to know this. But of course, it's a lot of new technology. It's very difficult to understand it if you don't have it in your hands, or if you're not using it. And that makes us less confident to talk about these systems, and makes us maybe not talk about and not giving our patients the option to start with these systems. Because I know most people maybe don't have the money to invest in AID systems, in insulin pumps and sensors, but some people might. And for those people, it's really important that we tell them about these options. So in the next hour, or sorry, half an hour, I'm going to talk about why AID systems are recommended for people with type 1 diabetes. So really to drive this point home, what are the pros and cons of the different AID systems? So the Minimed 780G and the open source systems, and then how you can support people starting these systems as a healthcare provider. So you can be very confident and leading your patients to the best possible care that they can afford. I'm showing my disclosures, but to be clear, this talk is not influenced by any firm, so this is my own opinion. I'm actually an endocrinologist for adults with type 1 diabetes, and 50% of my time I only work around making educational resources about insulin pumps and glucose sensors, and I will talk about what we have created later in the presentation. And also, if it's okay for you, I will, at the end of the presentation, I will show a QR code which you can scan, so you can get the PDF of this presentation immediately in your inbox. So you don't have to take any notes. Everything is available for you. At the end of the presentation, I will share the QR code. So why are these AID systems recommended for people with type 1 diabetes? Just as a reminder, the AID system is the glucose sensor that measures the glucose, the insulin pump, and then the algorithm in between. So if the glucose is predicted to be high in the coming minutes and hours, the insulin pump will give more insulin. And if it is predicted to go low, the insulin pump will lower the insulin delivery or stop insulin delivery. And then most AID systems are hybrid closed-loop systems. So at the moment, users still need to enter the carbs they are going to eat, or the meals, or do a meal announcement. And they also have to say when they are going to exercise to let the pump know that they might need less insulin. At the moment, you can expect that if you start an AID system, on average, the time in range, which is the time between 70 and 180 milligram per deciliter, will rise with 10%. Your patients will have less hypoglycemia, less glucose variation, less diabetes burden, and better sleep. And here I just show, to drive home the point, that this is a recent meta-analysis. So in general, the time in range raises with 11%, time below range drops with 0.5%, and HbA1c drops with 0.4. And you can think that is not enough, that is not so much. But we need to remember that the patients that are in these studies have an average time in range of 60%. So these AID systems make it possible to get to that golden time in range of above 70%. So they really go from not within the guidelines with their glucose control to within the guidelines with their glucose control. So we can call it kind of a technical cure. And on top of that, if you start with a lower time in range, for example, with a time in range of 34%, this is the pivotal study like in the UK that made reimbursement possible. If you start with on average 34%, you go to 62%. So the lower your time in range is at the start of an AID system, the higher it will be and the more effect you will have. So in this means that in the UK, it's only reimbursed for people that are not so good regulated. Here I saw just on an image the mental burden, you know, the type 1, it's always balancing the cord, making these decisions continuously about taking less or more insulin based on all these factors. And it's really getting all those getting all that math automated. So it makes it easier for people living with type 1 diabetes to manage their disease. And how I always convince my patients to start with an AID system is that they will probably sleep much better, because in the night, these systems work very good. And so you have less hyper and less hypo during the night, and you will always start your day with a perfect glucose in target. So the guidelines are, these systems are very good. So we should recommend them to all people with type 1 diabetes and even to people with insulin deficient diabetes. They also have very good results. Even at diagnosis, you can recommend these systems. So whether you have a high or a low HbA1c at the start with, you will also always do better with an AID system, even if you're very young or old. If you're not always bolusing, the pump or the system will still make the glucose better because it will respond on the highs after meals. And even if you're not carb counting, you can use the systems with fixed meals or fixed carbs. And the cool thing is that these AID systems have the same effect in every part of the world. In every country where you start these systems, you gain time in ranges of mid-70s, in the mid-70s%. So this is also possible in India. It is available, and it really makes it actually an equalizer of diabetes care. So what are the pros and cons of the AID systems available in India? Here I show every available AID system. So there are a lot more systems. And I just want to show that the Minimed 780G is the most used system. So the system that is available in India is used the most. It has very good results. And then below, we see like a small percentage of people that is using these open source systems also. So these are the systems. I heard there already was a webinar on the Minimed 780G. So I will go quickly over the system where the sugar is measured by the sensor. It is sent to the insulin pump, the Minimed pump, which has the algorithm on it and which will deliver the insulin that is needed. There is also a View app, and with that View app, everything is automatically synced to the CareLink cloud where you can read out the reports. And there is a Follow app. These are the settings you need, with the target glucose, carb ratio, and active insulin time being the only adjustable settings for the automated insulin part. So this is actually a very easy AID system because there is not so much you can do or you have to do concerning to settings. Now for the open source AID systems, I'm just have the disclaimer that it's not approved by any medical instances, by any medical firms. It's also not needed because they are not being sold. They are freely available on the internet. So it's not that's why there is also no regulation needed or is not there. But there is a lot of scientific evidence, and Dr. Jyotidev actually summarized the evidence very well in 2020. And there was also some reports of the first people in India using these open source AID systems with very good results. And then in beginning of 2022, there was an international consensus created by 48 medical and legal experts from 25 countries and endorsed by several national and international diabetes organizations, which we can really use as kind of a proxy of a legal document, because it's really, as there are no legal frameworks yet, we need to try to make our care similar to the care of other healthcare providers worldwide. And this proves that this is really international standard of care of the way we can work. And they say that open source AID systems are as safe and effective as a treatment option similar to commercial AID systems, that there is enough scientific evidence, that healthcare providers should support patients and caregivers' autonomy and choice, and that we should learn about all the options and ensure that people have a clear understanding of the benefits and limitations of all AID systems. And then on top of that, in 2022, we saw the first prospective randomized control trial. So really a trial that is very good designed, similar to the pivotal trials of the commercial AID systems, that proved that people that used Android APS in this case, and they compared it to the not connected insulin pump, that in the AID group, there was a time in range raise of 60 to 70%, so the same as the commercial systems. And if you don't do anything, if you don't give AID systems, be it commercial or open source, there is the time in range stays the same, 57 to 54%. They saw that the AID systems were also safe. There were no significant more ketoacidosis or hypoglycemia, which is, of course, a thing that we are most afraid of. First, we do not harm. So that's when the ADA also pivoted their opinion. Now there is a chapter about DIY closed-loop systems in the ADA standard of care, that we should assist people that use open source AID systems. And here is a total review of all the scientific evidence from the Diabetes Canada. And they made a position statement that it's one step further, that we actually have the obligation to discuss all available treatment options, because open source AID systems are more accessible due to the cost. And we should be aware of our biases and the potential of inappropriate gatekeeping. So we should also connect people that are interested in open source AID systems to the peers who are willing to help them. Peer support is very important in the open source community. And here I show another position statement of the Netherlands. There is also evidence that if you build the systems for your patients, that this is safe. But to be clear, this is not in the guidelines yet. This is actually one step further. Normally, the people build the apps themselves, and we support, they get support from the community, and we support them like people that have other AID systems. There is also an AID algorithm that is FDA approved now. So this further proves the point that open source AID systems are as safe and effective as the commercial ones. On top of that, they might work better. Because here we show that Android APS is actually the first AID system that works as well with meal announcements as without meal announcements. So it can be used as a fully closed loop system, be it, of course, that you have the settings really tuned in. Like this is not that with everybody so, but this publication at least shows that it is possible that if you have these well-regulated people that are using Android APS, that you can get the same results without entering the meals with the unannounced meal function that is in the Android APS algorithm. So in a recent publication, Dr. Forlenzo said that until commercial systems have closed-loop systems without meal announcements that are affordable, because of course this is not possible yet with the commercial systems, there will be a place for open source AID systems. The most important system is the one that a person with type 1 diabetes wants and can use, and especially in markets where where commercial AID systems are not that accessible because of the price, it is very easy to argue that it is standard of care to recommend an open source AID system, although this is off-label use and this is like not regulated. So this is where we stand with the liability issue. In general, DIY or open source AID systems, they are more affordable. They are more adaptable to the patient because you can change any setting. And commercial systems, on the other hand, are more available and they are more accessible because they are more simple. If you see at the Minimed 780G, there's only 2-3 parameters you can set. That makes it very easy instead of the open source AID systems where there's 20 parameters. So it makes the barrier a bit higher. And here are more pros and cons about open source AID system and commercial AID systems. So open source is cheaper. You have CGM and pump choice. There are adjustable settings, transparent calculations. You have the newest algorithms with the unannounced meal function and the dynamic functions. You can bolus from the phone and from the watch. And there is a possibility to remote bolus. And this is something very important for parents with children with type 1 diabetes. If they see that the sugar is going up, they can remote bolus. And that is only available in open source AID system. On the other hand, they are not approved by medical authorities, but luckily we have these international guidelines that make them available, that endorse them. You have to build it on your own risk, but we know that the studies show that they are safe and efficient. You have to build it yourself, but there are guides. There is no customer service, but there is an online community that is very active. And of course, it's more complex because you have more parameters. The average cost I already went over. And here are the possibilities with all the connections. So if you have access to an older Medtronic pump, to a Dana pump, an old Rush pump, or maybe some Omnipods that you can get your hands on, it is possible to build a system with Android phone or with an iPhone. And most people use the Libre 1 or the Libre Pro. And here you see how it works. So you have the sensor, which is usually the Libre. Then you have the with a transmitter like a Meow Meow or a Bluecon system that sends the data to a third-party app. So this is also an app that you will have to build yourself. It's an X-Trip-like app. That app is on your phone, and on the phone, this data will be transferred to the Android APS app that you build yourself. And then the algorithm will calculate how much insulin you need and will send it to the pump you have. If you have a non-Bluetooth pump, like most people in India use the older Medtronic pumps, you need a little device in between, which is a Riley link, to make sure that the Bluetooth signal is being translated to a radio frequency signal. Then Android APS sends all the data to Nightscout or to Tidepool. Those are readout platforms where healthcare providers can get their usual reports. The data can also be sent to Dexcom Share through the third-party apps. And then there are a number of follow apps for the family members who wants to follow the results. It's kind of the same for DIY Loop for iPhone, only there is a lesser need to have a third-party app between the glucose sensor and the DIY Loop app because the connection is more built into the DIY Loop app. And this is the same for IAPS Trio. This is another iPhone or open source algorithm, but it's used less. So this is the most used setup, the Freestyle Libre with an NFC to Bluetooth bridge that goes to the app and then sends the needed insulin requirement through a Riley link to an older Medtronic pump. Here are examples of the Meow Meow reader and the Bluecon Night Rider. So there are a lot of videos on YouTube on how to use those and what are the pros and cons. And here are links to the user guides. So if you scan the QR code at the end, you will have all the links. And then very important is the peer community. I would not start an open source AID system without subscribing to any peer community. And I heard also in the Empower T1D group, there are some people who have experience. So in their communication channels, you can see where you can find your way to that WhatsApp group. But these Facebook groups, these WhatsApp groups, do not underestimate them because they are actually much more powered than the usual customer care of firms. So you will have a very fast answer normally. Then a little bit more about the algorithm. So Android APS uses a model predictive control algorithm, which means that it predicts the blood glucose based on several parameters. And those are the several colored lines you see at the right side of the screen. And so it predicts where the glucose is going to be in the coming 5 to 9 hours. And then it calculates the insulin required based on how far that glucose is from your target glucose, and then dividing that difference with the insulin sensitivity factor or the correction factor. There is a basal insulin rate that you have to set on the pump, like on a normal manual pump. And if extra insulin is required, the basal insulin rate will be higher. So there, every 5 minutes, there is a temp basal that will be calculated. And then that insulin can be given as a flat rate, or it can be given as a super micro bolus. It's a different way of giving the same insulin faster. Of course, if a hypoglycemia is predicted, the basal insulin will stop. This is another way of showing this. And then there are different features like AutoSense that calculates the insulin sensitivity of the past 8 to 24 hours and applies that to the insulin that's being given. Unannounced meal function, as I talked about, and auto-tune to calculate optimal settings. So to start an open source AID systems, you need the regular settings like target glucose, basal insulin rate, carb ratio, ISF, and duration of insulin action. It's the same as for regular manual pumps. And then for Android APS, there are some extra settings you can set. This is how it works for DIY loop. It's kind of similar. There are different predictions that are being calculated into one prediction. And based on that prediction, there will be more or less insulin required, starting from the basal insulin rate that you set. And then the insulin that is required can be given as a flat rate, which is stem basal only, or it can be given as an insulin bolus, that is automatic bolus. So it are just different ways to give the insulin faster or slower. And if the blood glucose is predicted to be low, the basal insulin will be suspended. DIY loop does not have AutoSense function or unannounced meal function or auto-tune, but they do have a dynamic carb absorption module, which gives more clarity about the carbs that you enter, if it is correct or not. So for DIY loop, you need the regular settings as for a manual pump. And then on top of that, there are some additional settings you can do. So in the last 5 minutes, I want to show you how you can support people using an AID system. So these are the available systems in India. And the first thing is that as a healthcare provider or as a patient, it's important that you know what options are available and that you can also discuss this with your patients. Know the pros and cons of all available systems and show people where they can go for more information, because it's very difficult to give a full overview of a system in office hours, let's say. Normally the education takes a long time. First, give people access and education on the sensor. Give people access and education on the pump they are going to use. And then usually before you put on the, you make sure that the pump and the sensor works reasonably well. And then before you put on the auto mode or the closed loop settings, it's best that you review the settings on the app or on the Minimed 780G pump, that everything is okay before you set the automation. Pump users need regular training, and very important, they need access to supplies. Definitely in India, it's important to ask people if they have enough supplies, if they not try to do cost savings by using less supplies. So this is something that is very important, that people have access to sensors and strips, because without an accurate sensor, the AID system will not work. Regular follow-ups, 24/7 support is available from the firms or from the community. And then there are a lot of peer groups that are open to help people on AID systems. Just some examples. For the Minimed settings, it's advised to set the target glucose at the lowest at 100 milligram per deciliter and the active insulin time at 2 hours. And these are clinical examples of people. If you start a patient on the Minimed 780G, these are the results after 7 days. So you see very good that the glucose variability drops immediately after you click on the automation. And here is a person who always had HbA1c of 10, 11, 12, 9%. And he really was motivated to start something new. And the moment we started the Minimed 780G, he was much better in control. And he was actually able to restart his life, because before he was really not happy with his diabetes, very frustrated, not working, and starting these AID systems can really make you feel a lot better also about yourself. And he's very active now. He has 2 jobs. Here is an example from Android APS. So it's recommended to put a target glucose on 100, 120, a typical duration of insulin action on 6 hours. This is typical for open source AID systems. And here are also some recommendations for the settings of Android APS. Here is an example. The moment you start an automation, you see that the glucose variability goes down, and you see the time in range goes from 64% to 82%. Here are some recommended settings for DIY loop. So correction range or target range on around 100 milligram per deciliter, a longer duration of insulin action typical for open source AID systems. And then the settings that need to be checked. And you see before and after immediately an effect of the automation. So it's not going to be perfect, and it's not going to be a flat line with everybody, but it will be better. That's for sure. So that's it. We talked about why AID systems are recommended, what are the pros and cons, and how to support people. And I hope that you remember that AID systems are recommended for all people with type 1 diabetes. And the best one is the one the patient can and will use. So it's not available or accessible for everybody, but some people might be willing to pay for this because it's actually the best care for their type 1 diabetes. Both Minimed 780G and open source AID systems are safe and effective, and all options should be supported by healthcare providers. And you can do that by educating yourself, educating your patients, and refer to peer support groups. And I hope that with all this technological cure, we can create a new and happier generation of people with type 1 diabetes, but without any complications, using glucose sensors, insulin pumps, and all this new technology and more innovations that are definitely going to come. Finally, I would like to invite you to the Diabetes Technology Expert Program. It's something I've been working on for a few years. We made the startup education of every glucose sensor and insulin pump available 24/7 online. So there are more than 25 modules. It's independent education. It's peer-reviewed. There is an automatic certificate possible. The general modules are accredited by the European Committee. And we have a monthly Zoom expert meeting where we talk with experts using those specific systems. And here is the QR code I talked about. So feel free to scan the code and you get this PowerPoint presentation in your inbox and also the links to the free courses.
Thank you, Dr. Inge. I would request all the participants as well as all the panelists and myself that will scan the PowerPoint. It was a wonderful presentation by Dr. Inge and very enlightening both regarding the automated hybrid closed loop systems as well as the more important do-it-yourself insulin pump delivery systems. It was an excellent primer as to understand how to use and how these DIY insulin pumps can make a difference in an individual's life, especially who is finding it very difficult to control or manage his life with type 1 diabetes. So I really congratulate you for an excellent talk. Now we'll head to the panel discussion. Uh, if the audience has any questions, please type them in the chat box. I would like to ask one very basic question to Dr. Inge, that what is the age group where we can recommend a DIY insulin pump, or below which age group we should not recommend, or something like that?
There is not a lot of, normally I know of studies as low as 3 years old, but of course, as it does not have any official age to start with, so you can start it. There is no specific age. I'm sorry.
Okay. No problem. And I would request Mr. Harsh and also Mr. Somsundar to give their views also whenever they wish to have their views on any question, even if it is asked to any one of them. So Mr. Harsh Kohli,
Yes.
he is a type 1 diabetics advocate from Delhi. And Mr. Nitin Somsundar, he is also a type 1 diabetes advocate from Hyderabad. And both of them are using a DIY insulin pump. So I think interacting with them will be very useful for all of us to understand how the DIY pump works. I think I would like to ask further questions to Ms. Melissa has also joined from UK. She is also a type 1 diabetes advocate, and we welcome you, Melissa, to this panel discussion. So I would like to start by asking Mr. Harsh, what are the main safety challenges that one has to navigate when he begins on a DIY insulin pump? Or any safety aspects are there that you see?
Hey, very good evening to everyone. And I'm Harsh, and I don't know whether you all are aware or not. I have had type 1 diabetes since close to 31 years. My younger son has it for the past 7 years. So I am on the DIY loop, and my son, he's on the Minimed 780G. So I am practically experiencing both the devices hands-on. So saying that safety, yes, safety is paramount. So as Dr. Inge rightly pointed out, that do not immediately shift to the closed loop mode. Learn your settings, test your ratios, particularly I would say your ISF, because if your ISF is wrongly set, you might land up in a hypo, which can be counterproductive, and it will put you step behind. Your confidence would be lagging. So that's the only thing which we need to overcome that barrier. And on a loop, it's more of a trust thing. Learn to trust the loop. The more you trust it, the more effective it will be. It's a gradual process. I saw it firsthand myself. It's been 2 years since I've been on the loop. Temporarily, I'm off the loop. The reason is because my transmitter, the Myo 3, it failed. It conked off. So I'm waiting for the replacements to come in. So otherwise, it's been a wonderful journey so far. I'm very happy, very satisfied. And the best part is the fear of hypos has gone away. Yeah. Nitin?
Yeah. So I think we would also like to listen to Mr. Nitin's experience of DIY insulin pump.
Um, Hi everyone. Thanks Inge for the wonderful sessions. Thanks Dr. Sanket for giving this opportunity. So
Can
I'm
you just
also
introduce yourself once? Yeah.
Yes, I'm Nitin. So I'm basically based out of Bangalore. So I currently work in Hyderabad, and also I'm a type 1 since the last 8 years now. So the initial days of my diagnosis was a roller coaster. I was misdiagnosed as opposed to being a type 1. I was misdiagnosed to being a type 2. So that's where my journey started with the management issues with respect to diabetes. So the first 2 years I was on metformin without being put on the right medication. So that's when I started exploring all of the technology that is available with respect to monitoring and taking care of your diabetes. But 2 years down the line, I was able to find out that I was not type 2, and I was actually a type 1 diabetic. And then once put on insulin, my HbA1c from being at 15 came down to 6.8 in a matter of months. So that's when I started exploring more on the diabetes technology that was available. So in the initial days, I was not on the DIY loop. So it was basically with multiple daily injections and managing it on my own. But I will have to mention the peer support group here in India. It was quite wonderful, and I was able to connect with quite a lot of type ones, and was able to get more insights on how they manage their condition. So that's when step by step I started exploring different diabetes equipments that were available. So I started off with CGM. I mean, before it was an FGM, so flash glucose monitoring system. So after that, I explored the option of converting it to a CGM, and then having introduced to DIY loop. So I came on to the closed loop system later. So now it's been close to 4 years now since I've been on closed loop system. So it's been wonderful managing my diabetes journey for the last 4 years with the closed loop system. And as Dr. Inge explained, like, it kind of improves your time and range throughout the day, and you avoid the number of low blood glucose episodes that you have, and you also sleep really well. So these are a couple of um, things that have worked for me personally. And I mean, I've been able to help others as well who have, I mean, who have contacted me or the peer support groups to get onto the closed loop system. And yeah, I mean, from what technology we have here in India, we are able to manage our diabetes in a better way.
That's great. Uh, Thank you, Mr. Nitin, for sharing your views. And we'll be asking you some more questions later.
Sure, no
So,
problem.
would like to ask Miss Melissa, who is from UK. She is also passionate type 1 diabetes advocate, to share her views regarding DIY insulin pump and how it can be beneficial for patients with type 1 diabetes.
I grew up in the US, so I do sound like I'm an American because I'm an American too, although I've lived in the UK for 20 years. So my journey to using DIY started when I went to the ATTD Diabetes Technology Conference in 2017, and I saw a presentation in a corporate sponsored symposium by some DIY users talking about their experiences. And I had thought, it's all very beyond me. I won't be able to figure it out because it sounds very technical. And I prefer to have a company support line I can call for my insulin pump or my CGM if something's not working, because I had a pump since 1996 and I had technology failures. And I thought, I need to know there's always someone I can call who is on the other end of the phone line. But also, I was challenged because I had had one very healthy pregnancy, and my baby boy, born in March 2015, was was wonderfully healthy, all good. And yet I got postpartum thyroiditis after that pregnancy, and my diabetes became much less manageable as a result. And I really never knew that that was a possibility. I know from having been included in a research study at the National Institutes of Health in the US, when I'd had type 1 for only 11 years, that I still had residual production of C-peptide, which would indicate that I was probably going to enjoy some protection from complications. Maybe I was going to have a bit of an easier ride in managing my type 1. But after I got postpartum thyroiditis, that was out the window. And I'd never seen such fluctuations in my own glucose levels. My A1C stayed okay. So my diabetes team said, whenever you're ready to think about extending your family and having another pregnancy, we're on your side. But I thought, I don't feel so good about this. But when I heard those guys speak at the conference, I thought maybe I need to give this a bit more consideration. And I thought I will join one of the groups and I will watch the conversations and see if I can begin to understand it better. And then I thought, actually, if I don't try this, I'm going to wonder if I let diabetes tell me what to do. And I've never been someone who let diabetes tell me what I could or couldn't do. So I thought, if it doesn't work, if it doesn't get me the outcomes I'm looking for to consider having another baby, then I can always stop using it. I don't have to keep with this forever. It's not permanent. So I gave it a try. And a few months later, I said to my husband, we're ready, let's go. And we had a beautiful baby girl in 2019. And I was the first person to have a pregnancy and delivery at St. Thomas's Hospital in London using a DIY loop system. The team was incredibly supportive, in some part because they had known me very well for a long time, and they were happy to be in dialogue with me regularly, but also because we were all learning together. And I could have decided to go to a commercial system after having the baby. I decided to stay with Loop and become part of the community because I've seen that it's a power to be able to help other people. And I'm now a moderator of the Loop group on Facebook, which has over 30,000 members. And we are the prime support group for people using the iOS Loop. And we will signpost people to the best support for them if they're using an Android APS system.
That's wonderful to know. It was a really nice to hear your story and how you went from being completely against to DIY to a pro, and now you're actually supporting several people with who are now going to DIY pumps. So that's a really remarkable story. There are a few questions in the chat box. This question was answered by Dr. Inge. How much does the DIY tool cost in India? I think you had put the cost in your presentation.
Yes, would you like me to show the slide? It was 130 lakhs, I thought, by a pump.
Not one, it was 1.35 lakhs.
Oh, that's how you say it. Oh, I'm sorry. I don't know what the lakhs. Yeah, okay. Thank you. I can show the slide if you want.
No,
but
okay.
I'm not sure, like Harsh was also telling about, it's not easy these days to get a pump. So there might be some other barriers too than the money.
And they are asking that, is there any side effect of a DIY pump? So it's like any other pump. So
yeah, it's like the problem is hypo and hyperglycemia, just giving too much or too little insulin. Like in general, AID systems, no matter which AID systems, is always safer than insulin pens. But that is, of course, if you know how to troubleshoot, because you have no long-acting insulin on board. So you need to know that if your sugar is high, that you have a high risk on ketoacidosis, and you need to change the infusion set on time and have your insulin pen with you for if you have problems. And of course, there is a risk if you don't have the sensors, like you do need to have all your supplies. But in general, the risk of hypo and hyperglycemia is lower with pumps and with AID systems. That's why we use them, right?
So there's a second question, that is there any higher possibility of landing up with diabetic ketoacidosis in patients who are on a DIY pump versus a closed loop hybrid pump?
You mean more ketoacidosis with DIY?
Yeah. That is the question.
It's not been seen. It has not been seen. So the studies are lower. With commercial, there is more pivotal studies than with open source, but the prospective randomized control trials with open source AID systems, and there are actually 2 now, show that there is no higher risk on ketoacidosis compared to with insulin pens. So the same results as with the commercial systems.
Okay. So is there, what are the views of Mr. Harsh on this? Like, is there more decay that you have observed or while using the pump or anything?
Not at all. The only risk we carry is a pump failure, which Dr. Inge rightly pointed out, or the infusion site failure. So that can that can also happen if we are using the pump on a manual mode as well. That's the only thing.
The only thing I can think of is people might choose for open source AID system because of the cost restraint, and then they're going to start using their infusion sets very long and
Yes.
maybe not checking in the finger prick if or not changing their sensors enough, and that might put them on a higher risk on ketoacidosis. So you have to check if they're using it in the right way and they know their emergency protocols, and then they're fine.
And they should be having adequate supplies with them. That should be there.
Yes, they should have an insulin pen with them because pump failure can happen anytime.
Okay. So
we did see in the UK hybrid closed loop pilot, and this is, it's a finding. It's not a huge finding in the scheme of things, but among people who may not have had a whole lot of diabetes education and support on commencing a commercial hybrid closed loop system, some people saw there was a high amount of insulin on board delivered because of their system trying to battle a hyperglycemic level. And they thought, oh, my glucose will come down. It will come down. It must come down. But in truth, they had an infusion set problem and they really should have changed it. So that can happen whether somebody is on a pump without any automation and they just think, I've given myself so many units by bolus, it'll have to come down, or if it's automated. But it's an interesting thing, I think, to point out that if in doubt, change it out is still a good mantra.
So Dr. Rutul, who is also the founder member of Empower T1D, has also joined us. So, hello, Dr. Rutul.
Yes, hello everyone.
Hi, Dr. Rutul. Nice to see you here. Very nice.
If you have any...
Sorry, I have some technical problems. So
we can see 2 Dr. Rutul on the screen. Yeah. So, meanwhile, Dr. Rutul comes online. I would like to ask Mr. Nitin that on a day-to-day basis, what are the things that or the checklist that you need to have so that the DIY pump doesn't fail or does not have any troubleshooting? Or things you need to take care of on a daily basis or maybe weekly basis?
So, I mean, it all comes down to the connectivities that all of these apps and if you're using a phone or a tablet, so all of these devices need to be as close to you as possible. And that is one thing where one of the devices is not connected to one another, the closed loop system will fail. And then it is easily I mean, it can be easily fixed if you know how to reset and reconnect all of these devices. So that's one thing where in the initial times it can be a little overwhelming if you are not aware of how these systems work alongside each other. But then as you get used to it, it's quite easy to troubleshoot them. So that's one thing. And the other thing is you need to have batteries for all of these devices when you're using a closed loop system, because the pump requires a separate battery for it to function, and the Riley link which we were talking about also requires 2 sets of batteries for that as well. So, and also to have those integrated in your phone should also be switched on with the Bluetooth continuously on. Like all of these devices should be there in proximity of your pump to function properly. So once you've got all of that, and the loop should function good.
So the initial few days or weeks are important to
Yes,
get used to all these things,
right.
and then it becomes more easier for the individual.
Yes. I mean, it becomes a habit. We get used to all of these devices being on us.
I just
Uh,
Like
wanted
to
to point
further,
out.
yeah, Dr.
yeah,
Inge is saying
yeah,
something.
please.
Oh, sorry. I just wanted to point out that if the system fails, it doesn't mean that people don't get insulin anymore, because it will fall
Right.
back on the manual rate. So it will just be a normal pump, which is still okay, but it's not the automation.
Okay.
Right.
I still make a point to carry 100 IU syringe with me all the times, so
Yeah,
that in case there's some issue with the pump, I can manually inject insulin.
that is the advice is given to every patient, whether they are using a DIY pump or any other pump. We
Absolutely.
always tell, even if they are using a insulin pen device, sometimes when they are traveling, we ask them to take syringes also. Sometimes
Yes.
the pen can get broken. So the most basic is
Technology
the insulin syringe, which will never fail, I would say. So
technology does fail, and it will fail at least once in your use. That's what
yeah,
I've learned with experience. And one more important thing that I've learned is that we need to at least check our blood sugars twice a day. And over the years, I don't know whether how you people take it. I've got into the habit of checking my blood sugars
mhm,
before every meal,
yeah,
even though I'm on the lead, just to check the accuracy of my sensors and all these devices. This ensures kind of a foolproof mechanism, because we are fortunate that we can afford this technology. So do
yeah.
not shy away from
Making
measuring
it
your
look at
blood
it
sugar
deliver
levels.
100%.
Absolutely, that's the paramount, because the whole loop is working on one thing, and that's our blood sugar levels.
Yeah, too. That's a good point. Dr. Rotul,
Yes.
would like to
Thank
have
you,
your
Dr. Sanket, for and everyone. Thank you very much for joining, and especially Riddhi for coordinating so well. So I was going through everything, and I could understand one thing, that definitely it is more complex system than commercial system. There is no doubt about that. Commercial system is more simpler. As one of the question was asked to to Inge, that at what age we can start with DIY, and as low as 3 that I heard. But I guess it is really, isn't it so risky to start in such patients or kids with type 1 diabetes, especially when they don't understand exactly the system. The parents all the time have to be there with the system. Also, the other thing, what I'm understanding, that isn't it more exhaustive all the time you are there with technology, and as one side we talk about digital detox and all, and sometimes we have to be close to everything. I understand blood sugar should be in normal level all the time. This is what we want, and this is for what we are working for. But I don't know how you guys manage, and you are always there in your digital world all the time when you are using DIY, isn't it? Or you get exhausted sometime? Don't you feel so?
So, I mean, to answer that, I mean, it's I would not say exhaustive, but there are things where we can improvise and improve on the technologies that we have. So, to give you an example now, I may not look at my phone always because I still have a job to do and I have to move around throughout my day, right? So there is an improvement to the technology that I already have, so where I can also push the glucose readings from my phone to my watch. So whenever I see the time, I see my glucose as well. So that's also something technology gives you, like, it's not really overwhelming. I mean, you can predict uh, your hyperglycemia or hypoglycemia. So since using the closed loop also has a built-in feature where it suspends your glucose before your blood glucose goes very low,
Mm.
so you're always there to monitor your sugars. So that was just an extension of the technology that we currently have. Yeah, Harsh, you were trying to tell
Yeah,
something.
Dr. Rutul, it's nothing against the DIY loop because I am on the DIY loop. The thing that you just pointed out, that was the reason that veered me towards 780G for my son, because I could not think about handing him over a mobile phone, these many devices to carry with him all the time. So that's because children, they're not so sensitized, they're not too aware of the pros and cons of handling a mobile phone all the time. So now he carries 780G pretty well, and because with the DIY loop, yes, you need to carry those extra devices. But saying that, I found it to be better because we can lower our PG targets to even 90 and even 85, whereas the AID system, it does not allow you to go below 100. So it does not give you much more flexibility, whereas in loop we have a lot of flexibility. And Dr. Rutul, it does sound exhaustive, but with the community support, it is not. That's all I can say.
I've been going like this just to point out that another thing I carry with me is a battery pack for my phone, um, which has been a lifesaver on a lot of occasions. And sometimes it's not just my phone. Sometimes I've even been on a bus and somebody says, wait, I don't know if I'll make it to meet you because my battery is on 1% and I need directions on Google Maps to find the place. And I'm like, if you can take wireless charging, I can help you for 10 minutes. So sometimes that preparedness for myself has a benefit for somebody else. But I would throw that I have had so few overnight disturbances from glucose alarms since I've been on the DIY system. And it used to be that depending upon the time of the month, my hormones, my stress level, what activity I'd done in the daytime, I couldn't really get through more than a few nights a week without having a high or a low alarm. And now I'm so used to sleeping. It's more likely that one of my children will wake up and bother me for something at 3 in the morning. And I feel like that's normal life. The life where it could be 2 or 3 glucose alarms and a child walking into the bedroom, that's exhausting. So I've felt like I've enjoyed more of a regular experience with more sleep.
Yeah, I just like to add to this, like, although I'm not on the pump or on DIY loop, and I'm still on MDI with just moving to Meow Meow 3 has made life so much better. And I don't know why, but like I kept resisting embracing technology in my life. And just adding that bit has changed so much for me. So I think all of us here who are advocating for better management with type 1 diabetes, the sooner we embrace technology, the better it is. And also it's a personality type, like we just want to get better each day with our time in range and our T1D management. So then it's not as exhausting than to go through the hypers and the hypos. So I would say, like, from my experience, I think that's what's really very important and relevant for all of us to reflect upon.
I think it's well said that we have to adopt technology, and DIY insulin pump is also an excellent option for patients who are planning to transfer from a multiple daily insulin dose to an insulin pump device. So definitely in India earlier, I think it was just a theoretical aspect, but now it's more feasible with availability of people like Mr. Harsh and Mr. Nitin and all other support groups who are very willing and forthcoming to help others who want to go on a DIY insulin pump. So I think from the entire discussion, it seems that the DIY pump is definitely a wonderful option for patients with type 1 diabetes.
So I want to add something, Dr. Sanket. May I?
Yeah, definitely.
Yeah. So as we don't have head-to-head comparison with our uh,
Traditional
pumps,
insulin pump.
yes, 780G or any pumps. So how much are we ready for this thing as it is not approved by any of the body all around the world? DIY is not approved. So still, I guess community and doctors can get together and we should have head-to-head comparison for DIY and all artificial pumps that AIDs.
Yes.
So anyone wants to answer for this thing, or how much are we ready for this thing?
I think Dr.
I would say
Yeah, please.
there have been a couple of investigator-initiated head-to-head studies showing that the DIY options were non-inferior, although there might have been a slightly different rate of hypoglycemia, but also more of the people in the DIY group tended to get into time and range. So it's the lower targets, and of course, individual users' dynamics may mean that some people are higher time and range and also dipping a little bit into hypo when perhaps they could avoid those hypos, but maybe they are actually treating them very actively and they're not disabling hypos. They're just enough time that it shows up on the time and range analysis. So, but we have also seen in these small studies that if you look at the sociodemographics, the people doing the DIY solutions tended to have higher income, higher levels of education, and those are very much US characteristics, of course. But just in general, the access to diabetes technology around the world tends to go that way, where the people who have more resources also have more time to investigate what's available to them and to work with it. So just as a gloss on how we need to be ready. I mean, my healthcare team doesn't look at my devices when I go to an appointment. They don't have to look at my Loop app and check my settings. They look at my Nightscout data the way that somebody might look at the Medtronic CareLink data. And we look at the numbers together and we talk about whether we think that the ratios are working. But my team doesn't have to know where in the Loop app is that particular setting. We talk about how I can amend it.
I also want to point out, so maybe on that earlier remark of very young children and not being, so I just wanted to say that open source AID systems are off-label, any age that you use them. And I know off-label use is not what we are supposed to do, but as physicians, we on other medications and on other devices, we also have some experience in off-label use, and it's on us to weigh the benefits and the disadvantages. We have experience with off-label use of other stuff that we give our patients. And although it's not regulated, we do have position papers that have international consensus made. And it would be helpful if there would be some kind of Indian position paper or Empower T1D position paper to really get some more legal documents out there for if there is any point of worry or to be more secure, right, against any liabilities, lawsuits that could come. But normally it's not that there is nothing there. It's off-label, but there is a consensus that we can support it. And then you mentioned, yeah, we need first some comparison head-to-head studies, but like for the commercial AID systems, we also don't have them, and they will never come. They will never come in the amount that the pivotal studies are being done, and that should not stop us from using commercial AID systems. They are too good. And because they have proven that in prospective randomized control trials, the same trials that are there for open source AID systems. So in my view, we should not wait for any further scientific evidence to start at least supporting them. We should not, maybe we should not yet like give the apps or make the apps ourselves and take all responsibilities. The consensus paper does not say we should take responsibility as physicians. The patient is still responsible, but the least we could do, I think, is support patients and tell them about the option. It's better than not having an AID system. So
I think, can we take one last question from the audience? There's a question that a patient started an automated insulin pump, not a DIY pump, but somehow they could not, the automation was very overwhelming for the patient, and they went to the manual pump. So the patient wants to know that what can they do to optimize their usage, and maybe what went wrong, what can they do to go back to automation. So maybe we can have comments from all of you. What can they do? Because it's similar. The question is similar, that patient wants to start an automated insulin delivery device. So what would be your suggestion to them?
So I think what might have happened, what happens a lot, is that when you start automation, you have to kind of let go, and people are high and they cannot really manually bolus anymore. They lose a bit that control. Maybe that's what's happened. And it's really kind of trusting the system and letting go, and maybe having a lower carb ratio or something, that it's a little bit more aggressive. I guess it's the Minimed 780G because it's the only system available. But the first thing would be to go back to your diabetes team and see what went wrong. And there is no problem in going to manual mode and then restarting at a later time. But in general, most people that are on automated mode do not want to come back to manual mode. So something went wrong in the education and in the usage and in the settings, I think.
Yeah.
Very rightly said, Dr. Inge. What I've learned practically is that if it's a child, then carb ratio won't matter to that extent as the ISF would matter. Because anyways, the AID would be able to accommodate half a unit of insulin here and there. But what would impact more is the ISF, because if the ISF is, yes, so maybe you need to, as you rightly said, that go back to the drawing board, sit down with your diabetes team. See, that's primary, that's very important. Go back to the drawing board, sit with your doctor.
So, I mean, just to add to what Harsh was pointing out, so with kids, it's a little tricky to, have the exact amount of insulin for them, because their total daily dose is already low. And with the amount of insulin that they require, it's a little tricky. So the parents need to understand more on the ISF and the ICF parameters, so that they can give the necessary insulin properly. I think once they figure that out, they can come back to the loop.
Any other final comments from Melissa regarding DIY insulin pumps?
I would say the view that I took of, if I try this and it doesn't work for me, then there's something else I can try, applies to all of the automated insulin delivery systems. And sometimes it's the right thing, but not necessarily the right time, or it takes time to get around to the idea. We have a number of people in the Looped group who will post a question and say, I am just finally getting myself together to start on the journey of building my system. And because I'm a moderator of the group, I might check and see how long since they joined. Sometimes people have been a member of the group for a couple of years, and they've had things come up, and suddenly now is the time for them to get started, and the level of support is there. On the other hand, there have been some people who have come forward wanting a lot of help to get their system off the ground, and the community is very happy to help, but there is a line around medical advice where we have to say, we can't tell you what your insulin sensitivity factor should be. We can't tell you what your carb ratio should be. We can support you with links to some things to read about how to determine that and how to discuss it with your healthcare team, but we can't replace that level of advice. And there are some people who really are looking for somebody to just fix their diabetes because it's tough. Living with diabetes is never great. But there's that line between personal responsibility, healthcare support, and the community that we have to make sure we're always being supportive without telling somebody, this is how you do your diabetes. Because nobody can tell somebody that they have to work it out and figure out what works for them. So I think that's one of the things we like to say is do it yourself doesn't mean do it alone. And it also doesn't, and what I like to add to it, it also means we can't do it for you.
Thank you. Dr. Rutul, you had raised your hand. You wanted to say? Yeah.
No.
Okay.
I was just clapping.
Okay, class. Great. I think it was a wonderful initial talk by Dr. Inge, and then followed by a very interactive panel discussion. We really had a deeper understanding of DIY pump with all these interactions with Mr. Harsh Kohli, Mr. Nitin Somsundar, and Ms. Melissa Holloway, as well as Dr. Inge, Dr. Rutul, as well as with Ms. Riddhi. So I think I will now hand over to Ms. Riddhi for further proceedings.
Yes, before we move to the vote of thanks, I'd like to really appreciate the diverse experiences brought today on this platform by Melissa, Harsh, and Nitin. And what I feel really excited about at this point in India is, of course, the community support has always been there. The collaboration that is coming up. You know, we have wonderful clinicians who are supporting us in this initiative. So Empower T1D and Tie Up today is bringing and enabling this wonderful platform for us, wherein we can learn from, such experienced people like Dr. Inge with Melissa. You know, you have been trying these technologies and supporting so many people. We have our advocates also been supporting, like Harsh and Nitin, I know, have been supporting so many people on this. But what is really exciting is that today we are able to make use of this wonderful platform, this beautiful collaboration, and, bring together everything so that going forward, we can be, we can be the cheerleaders and take this education and awareness to every level and to every person living with type 1 in India. So with that, I'd like to hand over to Dr. Rutul. And on my personal behalf, I thank each one of you for this enlightening session. Thank you.
Thank you, Riddhi, and everyone, especially Dr. Inge, Dr. Sanket, wonderful moderation, Mr. Harsh, Ms. Melissa, and Mr. Nitin. Thank you very much for being there and explaining us as advocates. We really could understand it in a better way, that how DIY is one of the best options when MDI or even MDI fails, or even pumps are not there as an option. So definitely India is moving so fast, and I would say we are so good in adopting technology, and we are good in our soft power, that is software and technology, where combining together, India is really doing good. But due to some constraints, we are not able to explain it to our patients, and definitely will try our best to adopt this technology as fast as possible, and we'll try to explain, and we'll take all your help whenever it is needed, as you have been committed to your community so well. So thank you very much, everyone, again. And on behalf of Empower team, I'm really glad to have you all on board. Thank you very much again. So we can close the session here. Thank you.